be here with you in the morning in New York City and wherever you are. And Eric asked if I would talk about MDMA-assisted psychotherapy for PTSD, really in the context of psychedelic psychotherapy for PTSD, which is a fairly recent focus for many of us. And so I'd like to just tell you a little bit about it and take your questions. So I want to start with just defining what is a psychedelic drug. For most people, the word psychedelic conjures up images of the 60s and protests of the war and psychedelic drugs and psychedelic music and colors. But a psychedelic drug is a drug that promotes a change in the normal state of consciousness, usually with changes in the acuity of the senses. So if we think about consciousness as just simply an awareness of our own existence and state, an altered state of consciousness might be a state in which awareness of self and the world is experienced differently. So what do I mean by that? For example, colors might seem brighter, sounds might seem more robust. In some cases, one can develop synesthesia, which is a crossing over of the senses where you hear colors or you see music or those kinds of experiences. So this is my own definition. And the reason that I've chosen to define it by myself is because if you look in the dictionary, contemporary definitions of psychedelic drugs are still focusing on abnormal psychic states and effects such as hallucinations or severe perceptual distortions or maybe extreme feelings of either euphoria or despair, really with the idea that the person who is taking these drugs might have sensory awareness, but with diminished control over what is being experienced. And contemporary definitions also would lead you to the feeling that these drugs are dangerous and perhaps shouldn't be used by anybody. And today we're going to talk about them being used in a therapeutic context, but in almost any authoritative dictionary you might look at today, the definition of a psychedelic drug will reinforce the idea that these drugs might be dangerous. But it's really important to understand that there is a very long history of the use of psychedelics in many, many kinds of contexts. Most psychedelics are found in nature and are extracted from plants. And psychedelics have actually been used for thousands of years by shamans in indigenous cultures as part of healing rituals and spiritual journeying. So for example, mescaline in the peyote has been used, dimethyltryptamine, which is the active ingredient in ayahuasca, and of course psilocybin, the ingredient in magic mushrooms. And the purpose of taking these medicines in these indigenous cultures for healing rituals has really been to develop a sense of revelation, what we call a noetic experience or a transpersonal state, meaning a transcendent experience. Now, more recently, there are synthetic compounds, synthetic psychedelic compounds, and these basically fall into two classes of drugs, the tryptamines, such as LSD, and phenethylamines, such as MDMA. And when you ask which drugs are included under the umbrella of psychedelic drugs, well, there are currently debates about which drugs are psychedelic. For example, is ketamine a psychedelic? Is cannabis? Those drugs are certainly mind manifesting, so it really depends on how broad you want to go when you're using this term psychedelic drugs. Connoisseurs of psychedelic drugs will make a lot of different categories between drugs that are and aren't psychedelic by virtue of really their hallucinogenic properties or their ability to kind of create something called ego dissolution, which really is a state where your awareness of reality is challenged a bit. You may not be sure of your identity for a moment. You may not be sure of your geographic coordinates. You may be floating up to space, to heavens, or all such things. Now, there's clearly a renaissance in interest in the use of psychedelics and therapeutics. That's why I'm giving this talk to you today. But the term renaissance is important here because these drugs were actually used in psychotherapy beginning in the 50s until they were classified as Schedule I drugs in the United States by the FDA. And you might ask me, what kind of conditions were these psychedelics used for? Well, in the 1950s, of course, we did not have the DSM-3. And so people were free of the tyranny of specific diagnoses, but they were really used to open people up so that they can examine issues that might have been harder for them to look at. So I'm assuming that they were used in the context of trauma, anxiety, PTSD, and depression. But the designation that these drugs would be Schedule I compounds, which means that they present major danger with absolutely no potential for therapeutic benefit, just harm for risk, made research into their potential therapeutic use almost impossible. Now, when we talk about using psychedelics in mental health, in psychiatry, we're not just talking about taking a compound. It's not pharmacology per se. We're talking about having a psychedelic assist a psychotherapeutic process. So what do I mean by this? In psychedelic-assisted psychotherapy, the focus is on the fact that if you can create a non-ordinary state of consciousness, this might lead to a rapid, comprehensive, and lasting insight and self-acceptance. And it's the insight and self-acceptance which all people in psychiatry and mental health are really looking to help our patients achieve. That is what galvanized the healing and the symptom reduction. And the healing and symptom reduction will occur over time as this experience of being in a non-ordinary state of consciousness is integrated. So in a classic psychedelic-assisted psychotherapy protocol, the medication itself will only be taken a few times, sometimes even just once, during the course of a much longer protocol that will involve many sessions before and many sessions after, as I will explain to you. But the real point that I want to make is that the psychedelic allows the patient to penetrate the normal avoidance, guilt, or shame that obscure or distort their understanding of a personal experience or a condition that they're in. And usually these distortions that we have lead to this kind of immutable narrative that perpetuates symptoms or maladaptive behaviors. In the case of trauma, of course, the immutable narrative might be something like, I deserved for this to happen to me, or I should have done a better job, I am incompetent, or the world is really very dangerous and always will be. So it's these messages that we send to ourselves that then become entrenched, and it's very hard to dislodge them, as anyone who has treated a trauma survivor knows. So the idea here is that we still want to do the same kind of work that we would ordinarily do in psychotherapy, but the psychedelic is simply a catalyst of the process. If we could do it without the psychedelic, I think many people would be happy to do it without the psychedelic, but I think one of the things that we have realized is that that's hard to do. And just to give you a fantastic set of quotes that might put this into context for you. And it's about the fact that the psychedelic is really meant to be a tool that is used really to facilitate an insight. And the psychologist Stanislav Grof said that psychedelics, when used responsibly, will be for psychiatry what the microscope is for biology or the telescope is for astronomy. And really, that says it all to me. We're just trying to see something that just can't ordinarily be seen. But another really good quote is from the philosopher Alan Watts. If you get the message, hang up the phone. What that means is that the biologist doesn't sit with eye permanently glued to the microscope. He goes away and works with what he has seen. And that's really the ideal use of a psychedelic, to see something you can't ordinarily see and bring it back to the therapy. So I'm going to talk about MDMA for PTSD for the rest of the time. Um, so again, focusing on one compound, um, and focusing on one disorder, PTSD. And it looks like from very recent data that MDMA-assisted psychotherapy may provide a powerful treatment for people suffering from PTSD. And why do we want to really focus on treatments for PTSD? Well, look, and this is my opinion, but I think that current evidence-based treatments are inadequate, because even when these treatments are well tolerated by our patients, many times the gains are minimal. And I think the problem lies in study designs, liberal response criteria, and a rush to kind of ratify solutions because of the pressure to have them. And I've been talking about this really for a very long time in my career. In the beginning, the philosophy behind cognitive behavioral therapies really, I thought, was genius, actually. The idea of desensitization and extinction. Um, and the studies were reporting very high effect sizes, but when you really look into it, most of those effect sizes were generated by having a cognitive behavioral um, condition against a waitlist control. So it's not really the same as a placebo design, and a lot of really strict inclusion exclusion criteria that don't necessarily match clinical practice. And also the definition of a responder was a 12-point decline on the CAPS. If you're starting out with an 80, as most of our patients do, 12-point decline, you still have a lot of symptoms there. So even if you would have a 25% improvement in symptoms, which is good and will certainly give you statistical significance, you still have a patient that has a lot of problems. And in 2016, I wrote a commentary about this with Charles Hogue. And really the idea wasn't not to use these treatments. The idea was that we have to just do more than that. And the question is, what is the more? So what is MDMA? Well, MDMA is actually not a classic psychedelic. Among psychedelic connoisseurs, they would call MDMA an entactogen. And the reason for that is that MDMA does not cause hallucinations, and it does not really cause ego dissolution. With MDMA, a person is very grounded, still has their own identity, but it's a heart opener. It enhances feelings of empathy, compassion for self and others. It promotes pro-social feelings, the idea of feeling connected to other people, particularly the therapists who are working with you. So MDMA increases interpersonal trust. It reduces fear of emotional injury so as to make unpleasant memories less disturbing. And in this way, it also increases introspection, acceptance, and insight. So imagine that your PTSD patient is in this state. Well, this is maybe a really good state in which to try to do, try to process trauma-related material. So that's the idea. We're not replacing the processing of trauma-related material. That still has to be done in this model. We're just trying to set the stage so that it's much easier to do. So what does MDMA look like? It stands for 3,4-methylene deoxymethamphetamine. And I've drawn an amphetamine molecule here so that you could see that this molecule is almost perfectly embedded within the structure of MDMA, except attached to this benzene ring, you have a methylene deoxy group, which is really two oxygens attached to a methyl, here CH2. And the pharmacokinetics are very interesting. This is a fast-acting drug with a 30-minute onset and a peak at 1 to 4 hours and a 7-hour half-life. Stuff goes out of your system very, very quickly after a single dose. And in terms of the pharmacodynamics, what's happening when you take MDMA? Well, it's a triple reuptake inhibitor. So you're having a release of serotonin, norepinephrine, and dopamine, and oxytocin, cortisol, vasopressin, and prolactin. The primary mode of action of MDMA is thought to be at the 5-HT2A receptor. It's an indirect serotonin agonist. It results in having more serotonin in the synapse. It also acts on the serotonin transporter, which transporting serotonin to the nerve terminal, promoting serotonin release. It interferes with storage of serotonin. So any opportunity to have more serotonin available in the synapse is created by MDMA. And interestingly, these effects absolutely disappear when the drug is metabolized. So to me, what needs to be explained here, do I understand from what I've just said how MDMA works to produce the effects I just told you about of prosocial behavior? We're still missing some pieces there. I think what needs to be explained really is how these transient effects result in an enduring transformative change with psychotherapy. And this is a good time to introduce an idea that is very important when you're talking about psychedelics, and it's the idea of set and setting. In traditional pharmacology, what do we talk about? We talk about the properties of the drug, the dose, the purity, the pharmacology, the route of administration. But when we talk about psychedelics, we also talk about set. What is the intention of the person taking the drug? What are their physical and emotional characteristics? And we talk about setting. What is the physical environment in which you are taking the medicine, and who are you with? And this begins to unpack the difference between recreational use and therapeutic use, which might have very, very different intentions and settings, and therefore effects. So with psychedelics, context is important. It's not just the properties of the molecule, and this is a very hard concept in psychiatry and in neuroscience for people, so I'm emphasizing it. In terms of a brief history of MDMA, it was originally synthesized in 1912 by Merck as an intermediary compound for a hemostatic drug. It was patented in 1914 because psychoactive properties were discovered. It was studied heavily in the 50s and 60s by the US Army and CIA. We don't necessarily know everything they published on it, although it hasn't been declassified. In 1960s and 70s, therapists started using it in their practices, and this is largely due to the fact, not in the 60s, but in the 70s, there became a greater use of this in therapy because in 1976, a chemistry student introduced a chemist named Sasha Shulgin to MDMA, and he resynthesized the compound and published the methods. Sasha Shulgin's an interesting character. He's the godfather of psychedelics, he's known as. He originally worked for Dow Chemical. He invented a pesticide that made the company a lot of money, and then I guess as a reward, he got to basically study whatever he wanted in his lab. And he had just taken mescaline and decided to study that. Eventually, Sasha Shulgin parted ways from Dow Chemical and set up his own lab in his own house after getting a DEA license. He made a deal with the DEA that he would share information with them. And he published all of the stuff that he did in the chemistry literature, but also in these 2 volumes, Phycol and Tycol, phenethylamines I have known and loved, and tryptamines I have known and loved. That's what those letters stand for. And if you like chemistry and you're interested in the story of psychedelics, I highly recommend these books. And he used to invite people over to try the psychedelics he synthesized, and he developed a rating scale so that people could take the drug and tell him what they thought. I mean, none of this could work right now. I mean, eventually his lab was closed down. But his reaction to MDMA is what I want to share with you. I found myself able to remain completely clear and lucid. I had excellent recall. I found myself being able to think honestly. That's a strange term because you think of honesty as an interaction between 2 people, but to be able to be honest with yourself and think, why did I do that? I did that because of such and such was fantastic. it was an honest answer in an area where we're so used to denial or disavowing or to just hiding our feelings. I felt myself come open. I found it extremely exhilarating because I discovered a completely magical place. And so he introduced the chemical to a psychologist who was about to retire, who tried it, went out of retirement, and distributed it to hundreds of clinicians. And that's the story of how MDMA became widely used in therapy. But in the late 70s and 80s, largely because the synthesis was published, MDMA became a party drug. Often it wasn't pure MDMA, was cut with other substances. And in 1985, MDMA was scheduled as part of the war on drugs because all the evidence of the DEA suggested that MDMA has become a nationwide problem. I was very interested in this evidence, so I typed in MDMA in my PubMed search engine. And in fact, before 1985, there were only 6 articles ever published on MDMA. So I don't know what evidence the DEA actually used. And neither did a bunch of other people who went and petitioned the DEA to change their mind. And among them was Rick Doblin, who filed a lawsuit saying that the DEA had failed to make its case and that the drug should be scheduled as a Schedule 3. But Rick Doblin lost the lawsuit, but he just picked himself up and in 1986 founded MAPS, the Multidisciplinary Association for Psychedelic Studies, so that for the sole purpose of getting MDMA to be used in therapy. And this is Rick Doblin today giving his TED Talk, which I recommend. But importantly, this is Rick Doblin when he tried to sue the government. And so I'm sure that he did not seem the kind of person that the government took very seriously. This is what I've told him. I said, you should have gotten a haircut before you went back to the DEA. But nonetheless, he actually made great progress. It took a while, from 1985 to 2001. He did a lot of work, relentless work, trying to get the FDA to allow him to do clinical trials. And it finally happened. By 2004, the DEA granted approval. The first participant was enrolled. 12 years later, 6 phase 2 trials were conducted. And a year later, the FDA designated this a breakthrough treatment. As of last month, the first phase 3 trial was published and the second one has begun. And so I'm going to share with you just some results to give you a sense of the magnitude of the effect. My favorite phase 2 design is this one. I think it was the first one. There's an assessment and screening. There are 3 90-minute preparation sessions before an 8-hour experimental session, and then 3 sessions where you do integration, followed by another experimental session and another 3 integration sessions. They're 90 minutes long with 2 therapists. At that point, there was a primary endpoint. The patient was unblinded. And if they were on placebo, they could go back and get the MDMA. And if they got MDMA for these first 2 times and they wanted another session, they could get that too. So the protocol was 3 MDMA sessions and 12 90-minute sessions. So this is not just a magic pill for 8 hours. This is a long protocol. What do you need 3 sessions for to prepare for MDMA? Well, you have to create a setting of safety and support and trust. You have to get the patient's story, and you have to orient them to what's different about this therapy. And what's different about it is that the therapist is going to let them do all the work by trusting their inner healer intelligence and using a non-directive approach. You talk about the likely effects of MDMA. People think of ecstasy. I'm going to be high. It's going to feel good. Usually that's not the case when you're processing trauma. That doesn't feel good, and no pill can make it feel good. Many people say, I don't understand why they call this ecstasy. So you really do have to explain that while you will be in an open state and you might feel good in your body, and certainly you might not feel fearful in your body, it might still be difficult. You elicit fears and concerns, and you reconfirm your commitment to the process. In terms of the experimental session, a drug is given at 9 and 45 minutes later, a booster is offered. Usually it's about 120 milligrams and a 65 milligram booster. Heart rate, body temperature, and blood pressure are monitored. The patient has eye shades and headphones, listens to music, is directed to go inside. And the therapists don't present agendas or solutions. They remain curious and open and attentive in checking with the patients. So the therapists are following the patient's process, creating a sense of safety and really trusting that the patient will heal, which, you know, we don't really do that in most of our settings. We're very directed. If a patient starts to dissociate, we're very concerned about that. We remind them to be in the here and now. None of that happens. Patient dissociates with MDMA, the therapists go with it. The therapy room is highly comfortable, upholstered chairs. It's designed to be very beautiful. The session is over 8 hours later when the patient is sober, and usually there's arrangements made for the patient not to be alone overnight, and the next morning the integration sessions occur. So what happens? Here are the data. I hope you can see that on the slide, yes. So bottom line, the placebo, just having that amount of psychotherapy and those 8-hour sessions already decreased CAPS, this is the CAPS 4, by 20 points, which is considered a significant treatment effect according to psychotherapy studies. But the MDMA obviously did a much more thorough job of taking a patient from a start point of 80 to 25, which is really unheard of in our field in terms of the magnitude of an effect. So let me show you the crossover part. So when patients who received placebo and then were offered the MDMA, well, they caught up. They were able to get to the point that the patients who had not gotten placebo had gotten to. So that's pretty wild. And this is a phase 2 study. The new phase 3 study that just came out, these data are no longer embargoed. I got this from Rick Doblin, but they're not.
That's okay, Rachel.
In Nature and Neuroscience. Just want to make that clear for our audience. We're not doing anything wrong. The MDMA effect is quite gigantic, 0.0001 with an effect size of 0.91 accounting for the psychotherapy. That's pretty good. And yeah, this is just the percent change, which is very, very great in MDMA. Now in phase 2, we learned that these effects persist for up to 74 months, which is also unheard of in psychotherapy studies. Most people start creeping back. The side effect profile is very acceptable, very few dropouts in the study. And so the summary is 23% in the placebo group no longer meet PTSD, 56% no longer meet it at MDMA, but by 12 months later, people in the MDMA group continue to improve. So the process of integration is continuing to help people. And so study participants really have fantastic things to say, much like Arthur Shulgin. It's allowed me to really view this part of my life that we're talking about in a new way than I have before. And maybe one of the things the drug does is let your mind relax and get out of the way, because the mind is so protective about the injury. I got a glimpse more of what I'm capable of growing into, and I'm motivating to keep practicing openness until it gets more developed. That's the key. How does it work? I can pretend to tell you how it works, but my real answer is that we don't know that yet. Most literature on the effects of MDMA have focused on the negative effects of MDMA in the context of drug abuse, so we haven't heard anything from the literature in 20 years that would really help us understand why this isn't just bad for you. And that's a shame, because the literature is misleading in that the acute effects of serotonin depletion that people were suggesting were neurotoxic are really not harmful necessarily or related to any long-term neurotoxicity. the fact that there's been a conflation of data from recreational and therapeutic work has really been harmful to advancing therapeutics. So we're going to need to create the new science to investigate the issues relevant to MDMA-assisted psychotherapy as we go. And we're going to have to do something we've been doing in my lab for 15 years, which is studying the biology of psychotherapy, because we're going to have to do that kind of integration. However, it does seem that MDMA might promote fear extinction and memory consolidation. So it might, we have to try to find biologic mechanisms that permit a state that is conducive to trauma-focused work. So not being afraid of your memories would definitely be important. MDMA may converge on pathways important for neuroplasticity, which might allow this continued effective growing. And of course, there have been beautiful papers showing oxytocin-dependent reopening of social reward learning. And oxytocin in that whole pro-social feeling may be a very important key ingredient. So this is your brain on MDMA. You do see a reduction in the amygdala and increase in prefrontal cortex activity. That can't be a bad thing. But I'll conclude by saying that the integration of psychedelics and psychotherapy represents an exciting frontier. There are opportunities for scientific innovation. It's always important to revisit our ideas about how we've come to believe what we do. What's been easy is that many of us understand that we've been told things about MDMA and psychedelics that probably aren't true. We believed them for a long time. But the story of how MDMA was scheduled is a cautionary tale. It's important in general to look at things in a new way. And because that's what we're asking our patients to do with their traumas, look at things a new way. So we've got to do that as their providers. And I'm happy if there's time left to take a question or two. I'm not sure there is time, but thank you.
Absolutely stunning. Thank you so much, Rachel, for giving us that overview. If I may, I'm going to do a few things here. Yes. Here's Eric. Yeah, opening up. So if I may start a brief discussion, Rachel. I've been following your career for a long time, and we are colleagues, and we became friends along the way. And I just wanted to ask you, maybe on a little bit of a personal note, if you allow me, like, how is it for a researcher like you to kind of be introduced to such a revolutionary novelty in psychiatry or psychotraumatology, to be revisiting something that we may have known for a long time? But how is it that this turns up in your career that impresses you so much? Could you speak to that?
Well, I spoke to it a little bit. I mean, I think for a long time, I have been one of the people that have been less enthusiastic about the current status of our treatment approaches. Um, we tried to do studies like the one we're doing with Joseph Zohar about preventing PTSD or augmenting, using pharmacotherapy to augment the effects of prolonged exposure. Um, in the beginning, my reaction was, oh, this is just another gimmick. But I think going to the training, really being able to talk to many people um, that have undergone the therapy, and also I got to experience it myself. Part of the training is you have an option to participate in an FDA approved protocol um, with therapists so that you can see exactly how this works, which was really helpful. I wouldn't have understood it as well. And frankly, I couldn't believe it. I felt after the first 8 hours that I had just done 10 years worth of analysis. And it was gentle, uh, gentle but honest. I mean, all that's true. And so I thought, yep, I'm doing this.
Thank you for
Thank
sharing
you.
that also.
There are a couple of questions here.
Yes,
One is from Victor.
just come here just a minute.
Go ahead, Victor. Yes,
Yeah.
you may
So
open your
there is
a
a
question yourself.
Okay.
question from.
Well, thank you very much for the presentation. It really helped. Oh, still some echoes or something like that.
You're good, Victor. Go ahead.
Okay, so thanks for the presentation. I have been thinking a lot about also maybe getting into the psychedelic studies because it's really interesting and really phenomenal what the results are. But how do you set up such a study? Because in many countries it's still an illicit substance. How do you get it through the ethical committee? I can imagine that there are a lot of barriers to be taken before you can set up this kind of study.
Victor,
Yeah.
just say where you're from.
I'm from Belgium.
Okay, thank you. Yeah, Rachel.
Yeah, so right now it is hard because these substances are scheduled, they're legal to use, and so there is a lot of red tape and that you have to go through in order to set up a study. But your best bet is to work with, and the only way you are going to be able to do this is to work with one of the companies that are sponsoring trials. Our trial is sponsored by MAPS for MDMA, and we'll be working with other drug companies for looking at psilocybin. And so, you would apply to them. Maybe they would help you with their IND. And it's a long process. These drugs MDMA is scheduled to be approved in 2022 or 23. And it to get easier. And I believe that many people are lobbying to make it easier for investigators to do these studies. So right now, you know,
Sorry if I interrupt Rachel, but by just saying that please mute your microphone if you're not speaking. Only Rachel unmute, then we don't have background. Otherwise, it will be difficult for others to hear what Rachel is saying. Yeah, thank you.
So for now, my recommendation is that if you're interested in this, try to get into one of the trainings that is being offered.
Thank you, Rachel. There is a question from Philip, Sharad Philip. Do you want to present it yourself, Sharad?
Thank you so much, Dr. Rachel, for that very lucid presentation. I had two questions. So the first one
Just
was
say
about
where you're from, please. Just say
yes,
where you're from, please.
Yeah, I'm signing in from Bangalore in India.
Yeah, go ahead.
Yeah, thank you. So the first question that I had was about what was the what was the doses like? How do you see those doses which you have mentioned, have 120 milligrams and 65 milligrams as a booster dose? How do you see them in comparison to the recreational quantities which were being used, and how was the drug administered?
So people oftentimes aren't that concerned about dose when they're using things in a recreational context. And I personally have never used MDMA recreationally, so I don't know. My sense is that they probably use similar doses. I don't know about the booster. And usually in a recreational context, somebody might take MDMA with something else. So I really don't know that.
Okay.
But what's the second question?
It was about how do you administer it? How do you administer the drug?
Yeah, in a pill. Patients swallows a pill.
Okay. There is a question from Avinash Shekar. Do you want to present it yourself, Avinash?
Thank you for the talk. I just had a doubt.
Just say where you're from, please. Then we know the regional distribution.
I'm also from India. I'm from Mangalore.
Okay.
I just wanted to know were there any side effects to this therapy, and also were there any dropouts in the studies?
Yeah, so side effects is an interesting word, right? People who are processing trauma may be quite distressed, and one common reaction after MDMA, although they didn't report it that much in the study, but it's common in recreational use, is for patients to feel a little depressed as the MDMA leaves their body, kind of a serotonergic type of effect. I would say that there are psychological side effects, but I wouldn't call them side effects. I would say that this is what's supposed to be happening. If you're doing clinical work and processing difficult material, you're not going to feel good about everything every minute. you're going to kind of be dysphoric a little bit, or you might be sad. I think the idea of the preparation and integration is for the therapist to allow you to hold those feelings and to use them and to recruit those negative feelings towards the goal of healing. You have to feel the bad before you come out the other side. Now, in traditional psychiatry, sometimes we're afraid of affect, ironically. And if somebody gets too sad or expresses too suicidality or things like that, we don't have a lot of capacity to tolerate those feelings. Now, obviously, suicidality should always be taken very, very, very seriously. But the idea here is to really ensure physical safety, to expect and anticipate that somebody may feel quite pensive, sad, dysphoric, but then work with that if that does happen, and monitor that very, very carefully. So, yes, I wouldn't see it as a side effect. I would see it as part of the process, though.
Yeah.
Thank you for
Thank you,
saying
Rachel.
that.
Eric, you might have a comment on that.
Well, I'd like to ask Bob Persano, because also maybe using it a little bit as a cliffhanger. I know that you have to leave us in a short note, but maybe this is an opportunity also to ask. I know I'm putting you on the spot. If you want to comment on what you heard Rachel speak, Bob, would you like to just have a comment or a question or a reflection to Rachel? Please go ahead.
Yeah, I mean, Rachel, as always, is at the cutting edge of what's going on in terms of our treatments, particularly for PTSD, but more broadly across the whole area of mental health, mental disorders, and recovery. The one I might ask as a transition, I don't know, Rachel, if you have any comments on ketamine, which clearly derives from, I mean, your institution was at the lead in our work with that. That is out there being used and is now becoming a critical part of our interventions for suicide risk in particular, which I'll make comments on later.
So ketamine paved the way for this, because I think they took a lot of the arrows about what do you mean you're using a party drug to treat depression and suicidality. So I think that kind of paved the way for the use of from party to clinic kind of situation. I think ketamine's been wonderful. I think we all know that the effects of ketamine don't last as long as we want them to last, and people have to come back for more ketamine. My feeling about that is that psychotherapy is not part of the ketamine protocol, and if we could use the opportunity, the dissociative state of ketamine is not similar to what happens with MDMA or psilocybin. However, it is interesting, and if we integrated some psychotherapy with it, not during but after, because you can't talk during ketamine, I think it would go a longer way. And it just wasn't built that way. And I think that MDMA is trying to not make that mistake. And we'll see about psilocybin, because their emphasis on psychotherapy, it's not as much as MDMA, it's more psychological support. So I think the lesson of ketamine for me is, let's not forget the psychotherapy, because a medicine alone is not going to get you permanently where you need to go. That there's no bypassing that. But I could be wrong about that. Other people who are experts in ketamine might have issues with it, but that is what I do think.
Well, thank you.
I hear from you now, Bob.
Yeah. Rachel, I think the point that you are making is very important, and I think to some extent it's the same point that are using in OCD. You don't treat it only with medication. You need to treat it with other type of thing, and only the synergism is giving the best result. So in this regard, it's it makes a lot of sense. If you can take the last question, is it okay?
It's okay with me.
Yeah, Sophia. Yeah, Sophia, do you like to ask the question?
Yes, I do. My name is Sofia. I'm from Ukraine, and actually I'm curious about acute toxicity of MDMA. So how, in a practical sense, we can avoid the risk of acute toxicity, and what to do actually when during experimental session patient experiences this acute toxicity, for example, with severe PTSD, because I suppose it can be a iatrogenic effect.
What do you mean by toxicity?
I mean, like side effects of MDMA, for example, during this first experimental session.
Right. So one of the things that I'm going to let Eric also correct me if I'm wrong, but one of the things that we really learn in the training is how to hold space for the patient and how to tolerate incredible distress. This is the productive distress of the work. This isn't a pharmacologic side effect that needs to be rescued. This is a process that the patient has to go through. If you're with them and you're monitoring their vitals and you've had the preparation and you know that their physical status can tolerate this, you're giving them a single dose. It's not toxic in a single dose. They could have a very difficult experience, but you're there to kind of, it's like labor. You'd be helping a woman through a difficult labor too. We're not telling her to stop the process. That's not one of the options, right? You got to see it through. And that is hard. That's going to be part of the training as a field, that we are going to have to be able to know the difference between a real medical emergency and a psychologically distressing state that is difficult for us to tolerate. That I think in our study, we have an MD and a PhD or a social worker. And I think that is a nice balance of, they're going to balance each other out very nicely around these. But we did have a lot of reactions by our MDs in particular. I would take somebody to the emergency room at this point. And in the training, it was, well, yeah, but that wouldn't be the right thing. Let's wait 2 hours into the video and see what happens. Mm-hmm. And so that's why the training was so powerful for me, because 2 hours later, it looks a little differently. It's not a drug toxicity issue. It's the drug stirring up, allowing the patient to open a door of, the kind of things that happen to people are awful. And that's why they have trouble reliving them. But we expect it, we're prepared for it, we're trained for it, we prepare the patient for it, and everyone's actually safe. And if they're not safe, we will tell by the vitals, and we will be in a medical setting or close to one in which we can do what we need to do for the patient. But Eric, you might want to.
No, I'm not adding, because we can talk. I really got you going, and this is wonderful to hear. And we can talk for many more minutes or hours about this, because it's very exciting.